Okay, we are recorded, so make sure you watch what you say, the eye rolls and everything. Make sure, because it is not going to be deleted. So, without further ado, again, my name is Micah Hunt. And Mikkel, what are you? Are you worried? You looked confused.
I'm laughing at Peter and his excitement.
He is an excited person for sure. So again, my name is Micah Hunt, and I am the host with the most for the Virtual Presentation Friday, holding these every week, free 1-hour CEU credits every week. And we've been doing this since May of last year, ever since the pandemic was at its peak, which is still kind of there. We're getting some vaccines getting out and been seeing a lot of posts on that. So for those that are getting vaccinated, congratulations to you. For those that haven't yet, hang in there. It'll be coming around soon enough. But again, we've been putting these together. We have speakers from all over the country and outside. We've had speakers from Canada and Australia. Somebody was actually joining us at 1 a.m. On Australia time with our 11 o'clock a.m. So I felt bad for her, but she hung through it. So these are all educational information and providing resources to our attendees, our virtual attendees. So again, thank you all for being here. Without further ado, we will now hear our speaker, Margaret Roche, who is the founder and the owner of Roche Dietitians, with her presentation. And Margaret, I'm going to let you take it away. So everybody, I will now shut up.
Good morning, everyone. Thank you, Micah, and thank you for inviting me. I feel really honored to be among such a wonderful group of folks. I thought what I would do first, and I've got a great set of slides for you, but apparently I can't see the slides in the chat at the same time. So I do have some chat questions for you, just so I can make sure that I tailor my comments to who you are. So would you mind putting in the chat, one, what is your discipline? You know, what type of work do you do? What is your role? And two, where is it that you do your role? Are you in a community-based setting? Are you in a, do you work in the industry that supports senior living? What type of senior living do you support? Home care, etc. I'm really curious to see who you are. Home care director of operations, wonderful. Thank you, Brandy. And let me know so that I can kind of talk a little bit more about, and I'm glad to hear about home care because I have an idea. Occupational therapy, community-based, 55, wherever they are. I love that. To Lucy, thank you, Lucy. She teaches to 55 plus. Hey, that's me. I'm going to hear what you have to say. ED, National Physiatry, physiatrist to skilled nursing, wonderful. Skilled home healthcare director, wonderful. Administrator for nursing home, but my background is nutrition. Thanks. Kanchana, thank you. Julie Moore, gerontology, home care agency director. Love the home care people because I'm working on something. Education and training background in gerontology. APS, director of sales and marketing, ILALMC. Thank you, Jeremy. Catherine, CCRC director, medical outreach and geriatric practice. Nice. Area agency on aging, long-term care supervisor. Wonderful. Did we slow down? Assisted living ED, retired. Okay. Social services. Alma, thank you. I think we slowed down. I think everybody who wanted to type, I'll give it one more minute. RDN, working at senior services. Hello, Kristen. Nice. Southwestern Virginia, thank you. So we got a dietitian in the house, 2 dietitians now. Writer for Caring for the Ages, provider, patient pattern communications consultant. Nice. Thank you, Joanne. Oh, you guys are fascinating. I love it. Micah, you got a nice group here. I love this. All right, good. Okay, one more, assisted living administrator, good. I got stuff for you guys. I'm really glad I did this. Okay, I'm gonna move on. This is thank you. I know you guys know each other, but for me, that was awesome. All right, hold on a second. Hold on, I gotta get you back so I can control myself here. And I'm gonna share my screen now. Share. All right, here we go. And there's our pal Micah. So anyway, thank you for bearing with me on that. It's really going to help me give you the kind of information that I think will work for you. Okay. Resume the slideshow. And here we go. Please let me resume my slideshow. Sorry about this, guys. We did practice this. Like, I don't know why I'm having trouble with this. I'm going to do a new share.
It's all good. We did practice this, and it's technology. What can we say? Just bear with us another minute, everybody.
I think what happens sometimes is if I have this other screen up, it has to do with how I did this. Okay, let me try this one more time. I think I'm going to close my slides and open them up again, and I think that'll do it.
So for those that are just joining us, please make sure that you chat that you're here, where you're watching from, and then also what your service is. Where do you work? What do you do? And in what field do you work in? That would be very helpful for the speaker to know, because I know we had quite a few people still joining us just as we speak. So, and again, if you're on the phone, if you're listening in, please make sure you email me that you're here so you can get the CEU email after this call. So again, please and thank you. And looks like we're getting, we can see your next slide again. There we go.
How about that?
That looks better.
All right. Thank you, everyone, for hanging in there with me. I think you just have to restart it. Okay. So let me get you started. We already did this. Welcome. It's good to know who you are. And now let me tell you a little bit about myself. I'm Margaret Roche. And I am a registered dietitian with a master's degree in clinical nutrition. I'm board certified in gerontological nutrition. I am a specialist in diabetes, as well as a fellow of the Academy of Nutrition and Dietetics, formerly known as the American Dietetic Association. I still stumble on that. And more importantly, you probably want to know what I believe in. And I believe in the transformative power of nutrition, especially for the older adult. And in the 30 years since I have founded Roche Dietitians, my mission has been to educate and empower those who nourish and care for older adults. And I hope to do that today for you. So let's move on and take a look at our learning objectives today. So today, our first learning objective is I'd like you to gain an understanding of how the unique nutritional needs of the older adult puts them at risk for malnutrition and dehydration, and how COVID-19 is exacerbating that. I'd like you to learn how simple, validated nutrition screening tools, specifically developed for the older adults, are a key strategy. I'd like you to get some best practices for nutrition interventions that work in the COVID-19 era for reducing malnutrition and dehydration risk. And I'd also like you to be able to identify how improving the quality and safety of foods for those with chewing and swallowing problems help reduces malnutrition. I've used this phrase a few times already with the older adult, and you know, we all know, all of us who work with older adults know that it is a very wide range of people. I guess in some categories I would be defined as an older adult. I have a very dear friend who's a dietitian who from Illinois, who's 86 years old, and I sat next to her at a conference recently, and the person giving the presentation kept referring, it was on older adults, and she works in that field, kept referring to the old being over 85. And every time he said it, she'd say, hey. So I try to be careful in my language with the older adults, but they are a broad range of persons, and many of us serve individuals such as this gentleman here, but they're not all the same. Many of us serve someone like this woman here, and we'll talk about her. I'm going to bring her picture up. By the way, this is a model. I bought this picture. I'm going to bring this picture up again. We're going to look at her again when we talk about the nutritional care of the more frail older adult. But before we move on even further and deeper into it, I want to show you this document. This is an infographic that was created by the nutrition advocacy group called Defeat Malnutrition Today. And Roche Dietitians is a member of this advocacy group. They put this infographic together to spread the word on the prevalence and impact that malnutrition has on the older adult. And those of us who work with elders every day, we already know this, but it's exciting to see that it's increasingly becoming part of the conversation, the advocacy conversation when it comes to public health policy. And I really want to share this with you because many of us know this working with elders, but I want to share it with you because this is part of the conversation that people are having now in Washington, D.C. This data was based on hospitalized patients. And of course, those we serve are the biggest consumers of hospital care. And so hospital malnutrition has a big impact on those we care. So up to 1 out of 2 or half of older adults are at risk for malnutrition. $51.3 billion is the estimated cost of disease-associated malnutrition in the US for older adults. Protein, calorie, malnutrition-related hospital stays are 2 times longer. So that means if someone is in the hospital, an older adult's in the hospital, and they have some type of malnutrition, they have longer lengths of stay, and they have more complications, falls, and 30-day readmissions. And those of you in home care know all about this. Protein, calorie malnutrition is likely related to hospital stays that are 3 times longer and 3 times more likely, I'm sorry, I read that wrong. They're 3 times more likely to result in death. And we know that those who are malnourished do not fare well. This is an interesting part that I think is really fascinating for those of us who really know the different types of older adults out there. You know, this bottom part here, age 18 to 39, you would anticipate that, you know, 107 versus 3,754 would be your protein, calorie, or your malnutrition related hospital stays per 100,000 in the population. That makes sense to us. But look at this number here, the difference between the 65 and 84 and the 85 plus. And I find it fascinating that from a nutrition perspective, and I'm sure many of you see this in other under other ways that you would evaluate an older adult, they had 85 plus, and even in my mind, it's like that 88 plus. It really seems to be a turning point, even for a more robust, vibrant, independent older adult. There's something about getting into that age range that we see more risk and more problems. And isn't that the age range that most of us are serving? So I think that's really interesting. And then look at this. This is part of that infographic, and they're saying just 4 steps can help improve older adult malnutrition care. 1, screen all patients. Now they're using the term patient because this is, again, hospital data. 2, assess their nutrition status. 3, diagnose the malnutrition, which is interesting. This is part of that whole conversation we're having, which I think is really exciting. And 3, intervene with appropriate nutrition. And I know the other dietitian that is on the call here today would say, hey, this is what we do all day. This has been my life's work. So I just love that it's getting out there more and more. And for those of you who are in community settings and in home care, I'm going to show you some details about this in terms of what we can do and even what non-licensed care providers can do to help in this process. So that's exciting. And then I want to give you another term that I want to make sure that's part of your vocabulary. And again, another emerging conversation we're having in the nutrition and the older adult world, and that's sarcopenia. Sarcopenia is defined as age-associated loss of skeletal muscle function and muscle mass. It occurs in approximately 6 to 22% of older adults. And this is significant to us because, of course, and you know, this muscle strength is a determining factor of a person's independence. And a person's independence, of course, is related to their quality of life. So this is something we should all be aware of. And sarcopenia is treated with resistance-based physical activity and a protein-rich diet. And this to me is exciting too, because for the first time we're seeing recommendations that are coupling nutrition and physical activity. I think we do have a few physical activity and even a few PTs on the call. It's the first time we're seeing that for the older adult, and I'm loving this. And this is a very specific recommendation to treat sarcopenia and prevent it. So that to me is really interesting. Another way to kind of think of sarcopenia is we all know the term osteoporosis, which is, you know, a thinning of the bones. Sarcopenia is that loss of muscle mass that's age related. Okay. Now, again, we in the nutrition world and in the food world with seniors, we know about this, we anticipate it, and we treat it. So I recently did, at the end of last year, and I don't mean April, I mean November. Last year, I did a webinar, and it was all dining professionals, dietitians, dietary managers, chefs. And I asked them this question: how concerned are you about the nutritional status of your residents since COVID-19? So if you had the two top ones, extremely and very, we're at what, 82% said that they are very concerned about the nutritional status of their residents. I anticipated that. I knew that we were going to have these high numbers because this is what we do. We know we were in lockdown. We knew the dining rooms weren't open. We knew people were isolated more. We had some concerns. Now, again, we've got systems in place. We monitor weights. We look at people. We have ways to add extra calories, etc. So I asked the next question, and the next question was, have you seen an increase in unintentional weight loss in your communities? And this blew me away. 53% said that they've seen an increase in unintentional weight loss. Now, remember, we've got systems in place. We monitor, now again, in independent living, it's a little different, but in assisted living and skilled in particular, we weigh people every month. We monitor their weights. We check and actually calculate percent weight change. We're all over this. So and we anticipate it. So to see a 53% increase in the actual outcome of unintentional weight loss, this blew me away. I was stunned. And as a matter of fact, I do a monthly newsletter, and that next month, the headline on my newsletter email was, I knew it was going to be bad, but not that bad. Not this bad is how I wrote it, because it really did stun me that we were seeing this in the in actuality. It just hit me hard. So let's talk about what this is about. And this is a slide that I've used for years, and I kind of blow through it when I talk about the nutrition care of the older adult. So let's look at this, the psychosocial aspect of what we're talking about. So let's see. Here's the funnel, so to speak. And when we have someone who comes into our care, so this would be someone under home care, someone into a community setting, etc. There's a certain amount, once you have to be under care, so to speak, there's a certain amount of autonomy that you lose. We know about this. We plan for it. We anticipate it. We've got people who come to us with dementia. Yes, that is an issue. Again, we know there's going to be nutrition and feeding issues related to that. We can anticipate it. We can take care of that. Therapeutic diets. For those of you who are not in a community or a skilled setting, therapeutic diets, things like low sodium diets, low fat diets, even diabetic diets, there's been a very strong effort since 2014 to eliminate therapeutic diets for the older adult. Why? Because they put that older adult at risk for eating less. Anytime you restrict what somebody's eating, there's a better chance that you're going to put them in a position where they eat less. There's a problem with malnutrition in older adults. We've known this, so we try not to restrict them, not to mention person-centered care. Why are we the food police? Who goes to your house and tells you what to eat? So therapeutic diets, again, know about it. So we've been dealing with that. But this stuff, isolation, grief, sad emotions, anxiousness, depression, again, it was all part of the package, so to speak, psychosocially with older adults. But once they became under our care, that was something that we helped them deal with. Now, it really has made such a large contribution of their loss of motivation to eat. This is why we're seeing a 50% increase over what we've already we're seeing with unintentional weight loss with the older adults. So this is why we are right now at a crisis point in terms of malnutrition and the older adult, those we serve. Why do we care about people who do not eat well? Let me take you through this cycle of nutrition problems. So we've got somebody who's a poor eater. That means they're going to lose weight. If you lose weight, you have nutritional deficiencies. If you have nutritional deficiencies, guess what? You're at an increased risk for illness and infection. and COVID, right? When you are at increased risk for illness and infection, you're more likely to be frail, you're more likely to go to the hospital, and when you go to the hospital, you're more likely to have a longer length of stay. And then when you're frail, guess what? Your functioning is diminished, your independence is diminished, you're more likely to fall, you're more likely to die. If you survive that, you're a poor eater. And the cycle continues on and on. Again, in a setting where you have a dietitian and a nutrition program in place, you anticipate this for all older adults, and anywhere along the continuum, you are going to want to intervene. Hopefully before the poor eating even happens, but anywhere along here, we can intervene, and we have strategies for intervening. I want to say a word about obesity, because it is very common for us to have older adults that we care for who are overweight or obese. Because what the issue is, there are many people between the combination of a sedentary lifestyle with high calorie foods that are low in nutrients, especially protein, we run into the same problem of sarcopenia. A decrease in muscle function, a decrease in muscle mass, and decrease in independence. So even if a person is obese or overweight, we do still care and are concerned about malnutrition, particularly in how it would affect their independence. Just as an aside, the flip side of that, for older adults who are obese or overweight who want to lose weight, the recommendation is they should not engage in calorie restrictions under any circumstances, unless they also have some type of a weight resistance program in place. So that's kind of cool. All right. So I like to always start with the why. And in this era of COVID, I have really had to rethink my priorities in caring for older adults. And basically, my new priorities are really taking a pretty aggressive approach in looking for those who have malnutrition, and also looking at how I can couple that with socialization, looking for a way to get food in place with taking advantage of any way to socialize, because I know about my funnel problem that I have with that contributing to a decreased motivation to eat. So how do I know who, and how do you know who is at problems for nutrition? If you have anyone you're caring for who's in a community setting that has been locked down, you don't need to go through a screening process. I can tell you, you've got people who are at nutrition risk. I would imagine everybody's at nutrition risk. I'll make it easy for you. If you're in a different setting where people maybe are not locked down, or people are in their own homes, etc., there are validated tools, meaning research-based, that work, that will tell you and allow you to screen people for nutrition problems. So let me tell you a little bit about this tool. This is the Mini Nutrition Assessment short form, and this was done by the Nestle Corporation. The Mini Nutrition Assessment short form, meaning there's only 6 questions, is validated as a standalone screening tool. It's based on the full Mini Nutrition Assessment. It provides a simple and quick method of identifying elderly patients who are at risk for malnutrition or who are already malnourished. It identifies the risk of malnutrition before severe changes in weight or protein levels occur. It may be completed at regular intervals in the community, in the hospital, long-term care, or in the home care setting. It's recommended to be done annually in the community and every 3 months. It was developed by Nestle, a leading international geriatricians and leading international geriatricians, and remains one of the few validated screening tools for the older adult. It's been well validated in international studies in a variety of settings. It correlates with morbidity and mortality. And what I really like about this, besides that it's validated, meaning it's accurate, is that it does not require a licensed professional to complete it. So in 6 questions, we can identify our residents who are at risk for malnutrition, and anyone in our communities or under our care can do that, can be appropriate for this, and anyone can do this. Anyone can use the form. It's free as long as you identify Nestle and do not change the form in any way. By the way, there is also a self-reporting version of this. So if for those of you who are in the outer world community setting, you can use this as a tool, easily accessible, to give out to seniors and their family members to self-evaluate. And it's still very accurate and validated. So let me show you what this form looks like. Again, 6 questions. And this is the other cool thing about this, is that they give you some cueing questions. So the first question was, has food intake declined over the last 3 months due to loss of appetite, digestive problems, chewing or swallowing difficulties? Now there's some cues. Ask the patient, have you eaten less normal over the past 3 months? And I guess you would know the answer to that to many of your residents and patients. So then my point is, there's questions that help you get the answer that you need to complete the validated tool. It asks about weight loss. How much weight loss has happened? It asks about mobility. Are you bedbound or do you actually go out? D, has the patient suffered psychological stress or acute disease in the past 3 months? Yes, 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 yes. We're going to answer yes to everybody on that one. Neuropsychological problems. This has to do with dementia. And then I think we got one more question. Yes, and then the BMI is calculated and there's a BMI chart for you to do that. So then it's just scored. 12 to 14 points, normal. 8 to 11, at risk. 0 to 7 points, malnourished. And then this is the other beautiful thing. It tells you what to do with each, if you've got somebody who's malnourished, treat them. If you got somebody who's at risk, monitor and treat them. If you've got somebody who's normal, great. Rescreen them after an illness, after a year, or if they're in a community like assisted living or something like that, after 3 months. Of course, in long-term care, we've got separate systems for this. We see everybody quarterly anyway. But this is beautiful: assisted living, independent living, home care, community organizations, etc. And so what I've done in my work is I use this tool, and then I help home health care agencies, independent living communities, etc., come up with interventions, specific interventions on what to do with this, go cautious and stop category, the green light type tool that they have here, where then you come up with specific strategies on how to address this malnutrition. But I'm going to give, I said today I was going to give you 3 takeaways. So that's 1, screen. 2, impacting unintentional weight loss. So let's say you do have people who have lost weight. What do you do about it? Well, it's the almighty calorie, protein, carbohydrate, and fat. So it's the calories, vitamins and minerals, phytonutrients. It's nutrition. And let me give you an example. Now, this example I have is for a community situation, independent living, assisted living, skilled, but you can do this in, individual settings as well. Milkshakes. Cow's milk has a lot of protein in it. Cow's milk can have a lot of calories in it too if you use a high calorie, whole milk. Soy milk, if you're going to have to go with plant-based milk, soy's the way to go because there's more protein in it. The portions can be small. You can still get a lot of calories in it. If people take supplements, there's a lot of people at home who are using supplementation. It normalizes it when you turn it into a milkshake. It includes the fluid, so we don't have to worry so much about dehydration. Smoothies can do the same thing, so you can throw some fruit, etc. in it. But I recommend that we do not make juices and hold them, because older adults are part of what's considered a highly susceptible population when it comes to foodborne illness, and they should not have juices that are not pasteurized. So if you're going to make an older adult some juices, juice it up, but serve it right away. Hydration's an issue. That's a problem. Dehydration goes with malnutrition. So what are some strategies for hydration? Hydration station in a community setting should come to the resident. At home, we need cues of when we hydrate older folks and put it on the calendar. Don't forget food as fluid. Things like soups, juices, fruits, yogurt or drinkable yogurt, which is a great one because it also has the active cultures. Smoothies and shakes like we talked about. coffee and tea. And some people might say, yeah, but we're not going to get a lot of calories there. Think about Starbucks. Starbucks is probably one of the biggest provider of calories in this country. So adding to the coffee and the tea will really help. Ice cream, of course, is another source. And I like cereal and milk for this reason too, because it's fluid, it's food. And you know, they put the vitamins and minerals in the cereal, and there's a lot of, especially B vitamins that older adults need. So I'm always talking about cereal when it comes to older adults, and it's normal for them. They like eating cereal. All right, what about between meal snacks? Popcorn has very little calories in it, or if it does, it's that icky fat and lots of salt. So when we're planning between meal snacks, know our level of nutrition risk. Use between meals as a clinical intervention. You know, we're fighting malnutrition here. We've got a serious risk problem here. Plan, if you're working with an interdisciplinary team, plan with that team and take full advantage of the opportunity. And I'm going to give you an example of something that I've done, recommended in a senior living environment. A pajama party. Now we've got some socialization. Breakfast for dinner is a very popular concept with older folks. They love it. They feel like they're getting away with something. So, and it's a great opportunity to get some high quality protein in. Egg, omelet, mini cupcakes, those kinds of things are wonderful ways to get protein in. Of course, the sausage patties as well, and there's some wonderful low sodium versions available out there. Don't forget your fruit. We can count that as fluid as well. So what happens is, another thing that can happen is a cereal snack at night instead of popcorn, because again, like I said, the cereal has the vitamins, minerals. Throw some bran flakes in there, and you've added some fiber as well. I do this with kids too. You know, even when my kids were young, I would buy the Sugar Bomb cereal, but it was never breakfast food. It was a snack food, or, you know, nighttime snack, party food. Again, you can deliver foods in PJs and nightcaps, and involve activity teams in the community setting. All right. Oh, can I see the chat? I'm trying to see if there's any questions, and I can't see the chat. If there are any questions, Micah, go ahead and break in and chime in, because I know I'm going quickly, but I want to make sure that I address what's appropriate for you. And I know many of you are not in a independent living setting. I mean, in a community setting.
So far, it's been complimentive.
Oh, great. Thank you.
Of your information. And then I'll go into more what the asks have been as you finish. But I also received an email question whenever you want me to ask that.
Okay, I'll finish this up and then we'll get some questions. So let's see how we're doing on time. Oh yeah, we're doing great. Okay, good. I'll keep going. Thank you, Micah. So my recommendation number 3 is have plan for the most frail, vulnerable that we're taking care of. And I'm also going to introduce a new concept, and that is oral frailty. And many are saying that oral frailty should be considered a geriatric syndrome. And oral frailty is defined as difficulty in chewing associated with age-related changes in swallowing. So this is interesting. It's like, you know, which came first, the chicken or the egg? So we've got people who have sarcopenia. Of course, it's going to affect their chewing musculature, right? And so now we're setting people up now. You know, do you see it? Another one of these cascades of problems. They don't eat well. They become frail, and we see this every day in the people we take care of. So now they've got sarcopenia. It's going to affect their chewing and swallowing ability, and we have somebody at risk for dysphagia. So it's an important geriatric syndrome. And another cause can be a person's poor dental status as well. And of course, people with dysphagia, maybe from other reasons, for like stroke or cancer surgery, they also then become frail, have oral frailty as well. And I told you we'd talk about this lady in this chair for a minute. I love this picture. I use this picture, I think, almost in every presentation I do. One, because she's a model, you know, so they showed her in other pictures. I should get one of those pictures. And she looks completely different in the other pictures. But what I think is fascinating about this picture is, how do you know that this woman is frail? Even if she were not sitting in a wheelchair, take a look at this picture. There's some telltale signs that she's frail. And part of it is if you look at the fact she's in a wheelchair, okay, look at her clothes. I thought it was so interesting that they chose to put those clothes on her. They're way too big for her, which means she's lost weight. So that's already a sign that she's lost weight. And then look along, and she's beautiful, really, and she's obviously well cared for. I mean, she's an independent woman because, like I said, I saw her before. She's just a model. And I think she looks beautiful in this picture. But if you look along the side of her temple, she's got some wasting there. And along her jawline, you know, her face is kind of wasted in a way. And that's one of the signs that we use as dietitians to identify people who may have some, you know, form of sarcopenia or oral frailty. So I just think that's really interesting. You know, her hair is nice, her skin's nice and bright, you know, she's well cared for, but she does have some malnutrition problems, this lady. So I think that's interesting. And then I want to talk just a little bit so you know about this. And this has to do with what dysphagia is. And that's where food gets into the airway and it causes people to potentially choke, or the food in the airway could cause a problem with someone getting pneumonia, where that food causes an infection. So this is what we talk about when we talk about dysphagia. There's a risk for choking or aspirating food into the airway. And what we do, and again, I think because these are our most frail people, nutritionally, I want you to know about this, we either thicken their liquids or we puree their foods, or we mash or mince their foods, dice them to make it easier. So these are, you know, we make either textured modified diets or thickened liquids to help and aid in chewing and swallowing. And the reason why I bring this up is because these are our people who have chewing and swallowing problems, are even having a more compounded problem with malnutrition. We want to make their food easy to eat. We have to build in some nutrient density. We have to remember how we're going to hydrate them. And they still need socialization. And there's new changes coming, and I just want you to know about them, that your team who feeds folks are going to have to be trained on, and that's this. You're going to be seeing this everywhere now. This is the International Dysphagia Diet Standardization Initiative. There's just launched, well, it's been out for a few years, but they've just launched a real initiative in the States now. It is an international initiative, but they really want it going in the States. And what makes it unique, oops, hold on a second. Oh yeah, you can see that. What makes it unique is that we use forks and spoons to test the accuracy of the thickness of the food and the appropriateness of the food in terms of texture. So you might be seeing some of this terms like minced and moist, soft and bite-sized. These are some of the new diets. So I just thought I'd share that with you so you know. So in summary, I want to give you a few best practices. Things are going to be different for a while. We have to make good nutrition a priority based on nutrition risk. And I can tell you, everybody you're serving right now is at risk. And we have to define the social component of our nutrition strategy for whoever we serve. We have to remember there should be a social component to it. So I've got some calls to action for you. 1, know you have nutrition risk with those you are taking care of. 2, establish some kind of a process for identifying residents at risk using a screening tool. 3, get a dietitian involved, even if it's just to establish what your interventions are going to be, you know, when to call for help. But maybe you could come up with some strategies that can be implemented by, you know, other than dietitians or non-licensed professionals. Plan your nutrition interventions and individualize from there. So have some broad strategies, but don't forget you are going to need to individualize, because that's what we do. And 5, have a special approach for special cases, especially don't forget your textured modified people and what they need. And 6, socialize your interventions. Okay, now I want to invite you to stay connected with me. I do have a 4-minute brief monthly newsletter. You're welcome to sign up for. You can do that on my website or just send me an email. I love LinkedIn. That's how we all got to know each other. That's how Mike and I met. And so please connect with me on LinkedIn. I want to say Micah and LinkedIn in one word because you basically are LinkedIn, Micah. So thank you for your kind attention. I think we got some time. I want to make sure, oh, I'm right on time. I want to make sure that I get to all your questions. And I kind of gave you a broad stroke on this. Bottom line is malnutrition is what we're all dealing with now. So anyway, thank you. Thanks for your.
Thank you, Margaret, so much. Thank you so much. If you don't mind not sharing your screen anymore,
Okay.
if possible.
Stop here.
And then I will open up the floor to questions. And while everybody is trying to figure out what questions to ask, I did receive an email from one,
Okay.
and I hope they're still on the call. Yes, they are. So one of the questions that I received was, how do we decide what dietary restrictions to throw out during a situation like a pandemic?
Oh, that is such a good question. And I love that question on so many levels. First of all, it's not just during the pandemic. We're throwing out a lot of therapeutic diets. And I'm going to give you, and I should have mentioned this. So that's why I'm so glad about this question. There's something called the New Dining Practice Standards. Many of you, I'm sure, know who Pioneer Network is. They came up with a consortium of 13 or 14 organizations, like the Medical Directors Association, the Nurses and Long-Term Care Association, the Academy of Nutrition and Dietetics, you get it, physical therapists. Everybody got together and said, this is what we believe to be true based on research and our consensus. Therapeutic diets for the older adult are not appropriate unless the risk of malnutrition or the benefit of that therapeutic diet outweighs the risk for malnutrition. By the way, that's a quote. This document is loaded with easy to read, easy to repeat talking points. Everybody who works with older adults and have anything to do with feeding them needs to see this document. And that is the New Dining Practice Standards, Pioneer Network, 2014.
And along with that question, they wanted to ask both when the goal is maintain nutritional status and health, but we also want people to be happy and comforted.
Amen.
I guess you kind of answered that.
Amen. So you got diabetes, so you got to be reasonable about it. And you know your little butterballs who have diabetes, who they need to put some guardrails on it. You also know that 88-year-old lady that we just saw sitting in the chair, and if she wants a donut, give her a donut. Give her a donut. And I'll tell you a story from when I was a very, very young dietitian. I had a nurse talk to me about somebody who wanted a half a cup of ice cream who had diabetes. And I didn't know what to do because I thought, well, she's got diabetes. And the nurse is like, I don't think we should give it to her. We went back and forth. And I think we decided she couldn't have the ice cream. And you know what happened the next time I went back? The woman wasn't there. She had died. And so sometimes I think this is what we're expecting people to, we're expecting people to eat literally for the rest of their lives. So I think that helps the frame of mind. Again, you got somebody who's a little bit more robust and you're having trouble with their blood sugars. Maybe we need to change their medication. But those people are kind of far and few between.
Does anybody else have any questions? Because this was some good information and really helpful. I know a lot of people were commenting on your PJ party idea.
They like that?
A lot of people are like, I love that idea. So does anybody else have any other questions? Those that do not wish to share their screen, you're welcome to raise your little emoji hand if you'd like to. Otherwise, and then Margaret, a lot of people would like to get the slides, the presentation, if they can from you. So what I typically do is I'll let you keep it. And when I send out my follow-up email, I'll add your email to the bottom. And if you want the slides, please reach out to Margaret. So that way there could be more conversation, more dialogue, more education, and maybe a better relation with Margaret that maybe she would be willing to do another presentation for your team. And, kind of open up the spectrum, because I want to keep the networking going and the communication going. And you're not going to get that with me. You're going to get it from an expert, Margaret.
So Mike, if you send me the list of who's attended here, I'll send a follow-up email and I will put the links of the New Dining Practice Standards, the screening tool, and then I'm doing some work on home care that I'm just putting together now. So those of you who are in home care, I'd like to kind of get a little bit of a group going about that, because I'm working on developing some of these interventions for home care people. So I would appreciate your feedback as well. So I'll get an email out to you guys next week. Mike, if you could get me the list, and I'll respond to everybody and get you what you need.
Following this email, so Margaret, those of you that know, when you get the email, it'll have a document or a click at the bottom that you can download the attendee list for everybody that attended today. And Margaret, you'll be on that email. So
wow.
I really try to make this flawless.
Wow, that's impressive.
So, so does anybody have any questions? This is your chance. You have an expert. Anne, you're muted. You're muted, Anne.
I got it now. Am I all right now?
You're good.
Okay, Margaret, can you give us a list of some more snacks that we can use in assisted living? That would be, I like the idea of the cereal mixes. We do that with a little bit of sweet, a little bit of salty, a little bit, for them. But is there any other good snacks that you have? I'd like to add to my list if you would give it to us when we get our email.
I'm going to send you, if you don't mind, Micah, I'm going to send you also a link to General Mills. I've done some work with them, full disclosure, but they have what they call the Bell Institute. They really are dedicated to coming up with recipes. They have a whole culinary team who come up with things, and they have a few great videos on how to make, they even make they're the makers of Chex Mix. So they got 1 million of those. And then they've got other things like parfaits and puddings and overnight oats.
Yeah.
I love the idea of overnight oats, especially in the summer for our folks. So they've got a ton of it. And so I don't want to take credit for their work. And if it's okay if I bring in another brand, so to speak, Micah, I will include that link, because they do beautiful work, and they have chefs who've worked in long-term care and in senior living who do a great job. So I will definitely include that. And then those of you who are in home care, I am looking, since we're networking, I am looking to connect with more home care people as well.
All right. Well, does anybody have any more comments or questions? Okay, well then I will go ahead and stop the recording.